Dr. Komel, please, you can start.
Yes, we can start.
Start, please.
Hello, my name is Dr. Zahid. I'm one of the senior house officers in the brain department.
Yes,
Are
doctor.
you Mrs. Alina, 30 years of age?
Yes, doctor, I'm Irina.
Okay, so Mrs. Alina, we are here to discuss about your health condition, right?
Yes, doctor.
So before I start to explain to you, can you tell me what happened and how do you feel now?
Yes, doctor, I'm feeling okay now. Really, doctor, I have suffered today morning very severe headache. I felt something burst in my head, and I threw up many times also. My friend brought me to hospital, and the nurse gave me some medication via this drip, and they did brain scan for me that show no brain damage. Really, doctor, I appreciate your effort to make me better. Really, I am now better, and I'm keen to go home.
Okay, Mrs. Alina, I appreciate that, and it's good that you're feeling better. But
Yeah.
has anyone discussed with you that what we are planning as the next step?
No, doctor, no.
Okay, so I'm here to tell you about more about your complaints and what we suspect.
Yes, doctor, please.
So, when you came to us in the morning, you had a very severe headache and you were throwing up,
Yeah,
and
really, yes, doctor.
yes, so we did your examination and we found that there was also some stiffness in your neck as well.
Yeah, yes, I
So
have neck pain. Yes, you are right, doctor.
yes, so these features are quite alarming for us because you suddenly developed all of these features. So we did an urgent scan of your brain, which is called the CT scan.
Yeah,
And yes, you're right that we found out nothing wrong in it. There was no abnormality
yeah,
to see in the CT scan, right?
yes, doctor, yes.
So even though this is reassuring, but still, considering your symptoms, they are quite alarming for us. And your case was discussed in a team of doctors, which also consisted of the brain doctor and my consultant.
Yeah,
And it was felt that right now we should still keep you in the hospital to observe you further because we are suspecting of a condition called as subarachnoid hemorrhage.
what this mean, doctor? What this mean?
So right now I'm here to explain to you. Actually, there are around our brain there are a number of layers,
Yeah,
and sometimes what can happen is that if a certain blood channel bursts, it can cause some bleeding to occur to accumulate around the brain.
bleeding, doctor.
Yes, Mrs.
But
Alina.
doctor, I understood that brain scan is normal. So how can be bleeding, doctor?
Yes, Mrs. Alina, you're right, and I see that definitely if there is a very big bleed, it will be detectable on the brain scan.
Yeah,
But in cases where there's a very small bleed, there are chances that it cannot be picked up by the brain scan. So we have to rely on the severe symptoms that you presented to us with.
but doctor, what's the cause of this bleeding? I still young. I know this bleeding usually come in old people.
Yes, Mrs. Alina, you're right that in majority of cases the bleeding happens in old people with who are suffering from other problems like blood pressure or sugar. But sometimes what happens is there can be an abnormal blood channel in the brain.
Yeah,
There can be some ballooning of the blood channel, or there can be some abnormal communication in the blood channel,
yeah.
and this can make it prone to rupture and bleed.
But really, doctor, I cannot stay in hospital. I should go home. Really, doctor. So I can go home, and when I feel this headache, I come back to hospital.
Okay, Mrs. Alina, before you express your wishes, I appreciate them and I agree that you would want to go home now that you're feeling better. But can I tell you in a little bit more in detail about the condition?
Yeah, yeah, please, doctor.
Yes, so like I said, that there can be an abnormal blood channel that can burst, and this condition can present with the same features as you presented to us with, which is the sudden onset of very severe headache that one has never experienced before. This is a very severe headache which is associated with feeling sick and throwing up.
Yeah.
and sometimes the bleed can be so small that it cannot be picked up by scans. So we have other ways of finding out uh, to confirm the diagnosis that we have, because if it is not confirmed timely, it can have a lot of complications. It can cause um, it can cause fits, it can cause decreased conscious level, and can be life threatening as well.
So you mean, doctor, if I go home and this bleeding it happened, so this is maybe life threatening.
Yes, Mrs. Alina, I'm afraid
So
to say
for
that it
that reason,
can.
I should go. I should stay here in hospital.
Yes, Mrs. Alina, we would like to keep you in the hospital for now, when we'd like to observe you for any further symptoms, and we'll want to do another test to confirm the diagnosis, which I
So how
want to
long?
talk to you about.
How long, doctor, I should stay here in hospital?
Mrs. Alina, we're going to do a test on you, another test, which can detect small bleeds. This is called a lumbar puncture.
Lumbar puncture. What is this, doctor? Please explain me more.
Yes, Mrs. Alina, this test, what we do is that um, we take the person to the sterile operation theater, which is germ free, and we numb the back with
Yeah.
some painkiller medication. We properly clean the area, and
Yeah.
then we insert a very fine needle into the back, and we get some fluid
Oh, you
from
should.
around
You
the
will
back.
insert needle in my back. Yes, I know this. Yeah, doctor, I know this. I read about this procedure before, but really, it looks painful procedure, doctor. Really, doctor, no need
Uh,
now. No need. I can stay here in hospital, but please don't do this procedure for me.
Mrs. Alina, you're right. The needle can be quite fearful to some patients, inserting a needle to their back. But let me assure you that we make the patient as comfortable as possible. We give them any numbing agent to
Yeah.
give make the area as pain free as possible, and we use a very fine needle so that minimum pain is experienced by the patient.
Yes, doctor, but really, I read many stories in the media about that some people has developed paralysis after this procedure.
Well, Mrs. Alina, every procedure has its benefits, and we have to weigh those for the patient. And in your case, it will be very beneficial because it will help us confirm the diagnosis. But
Yeah.
let me tell you that there are some side effects, and these are very minimal when the procedure is performed in experienced hands of doctors who have done it many times before. These side effects can be very minimal.
Yeah.
The
What is
side
side effect,
effects,
doctor? Yes, please.
yeah, the side effects, they can be infection, but like I told you, we keep it very. We clean the area properly to prevent infections. There can be bleeding, but we
Yeah.
prevent that from happening by applying a very high pressure bandage to the area
Yeah.
after extracting the fluid, and the patient is made to lie on their back for a few
Yeah.
hours, and we keep
Yes.
observing them. Sometimes headaches can happen, but we have preventive measures to prevent those headaches as well. And
Yeah.
in very, very rare cases, paralysis can take place, but when the needle is inserted in the appropriate place, the
Yes.
chances of this happening are very, very extremely low.
So it's rare to occur these side effects.
Yes, Mr. Zelina, it can happen, but it is very rare when it is done by an experienced doctor.
So, doctor, really, I am feeling fit now, but according to your experience, you see that I need this test for me.
Well, Mrs. Alina, this test is very important because when we'll extract the fluid, we'll send it to the lab, and they will look for any traces of blood in it. And if they find these changes, which are indicative of the subarachnoid hemorrhage, then we'll have to involve our specialist brain doctors, and we will manage you accordingly to prevent any further life-threatening complications.
So, doctor, you mean that if you confirm that this bleeding, I need more further investigation and management.
هاي الورقة. Yes, definitely. We'll then manage you accordingly, and there are treatment options available to help control this and prevent this from happening again in the future.
So, doctor, if you see that this is important for me, no problem.
Okay, so Mrs. Alina, I'd like to ask you some more questions. Do you have any significant history of any illnesses in the past?
No, no, doctor, this first time for in my life.
Okay, or any medications you take? Uh,
No, no, doctor.
so, Mrs. Alina, what do you do for a living?
I'm secretary, doctor.
Okay, and do you smoke?
Yes, I'm smoking
How much for how long?
10 cigarettes per day since about 2 years only.
Okay. So, Mrs. Alina, smoking is also quite harmful for your health, and it can also cause a lot of negative changes,
Yeah.
adverse changes in our body.
So,
So, it
doctor,
is
do you feel that
advisable.
smoking can cause this bleeding?
Sometimes smoking can cause changes in our blood channels as well,
Yeah.
and these can actually worsen the state of our blood channels and our organs like heart and brain. So, it is advisable, and we can help you out to quit smoking.
Yeah, doctor, I appreciate your effort. Thank you. Thank you very much.
Okay. And do you drink alcohol?
Only on weekend, doctor.
Okay. Can I ask you how much?
Only 2 units.
Okay. And do you drive?
Yes, doctor, I have car.
So, well, at the time being, it is advisable that you stop driving because, like I said, that this situation, it can lead to some complications. So, it is better to stop driving until we sort out your condition and
Okay,
we
doctor.
treat you, right?
Okay,
So, do
doctor.
you have any concerns?
Doctor, really, if this test is negative, so I need to do more tests.
Well, if this test is negative, then we will be repeating the test after 12 hours to confirm that it
You
is
will repeat
actually
this
negative.
same test, doctor. You will repeat it.
Well, Mrs. Alina, I acknowledge that it must be very difficult to do the test again, but this is the best
Yeah.
test that will help us diagnose. It is recommended that the test should be repeated after 12 hours to be completely sure that there is no such bleed.
Oh my God.
And
So why you to do twice? You can delay it after 12 hours and do it after 12 hours only.
well,
2 minutes.
Mrs. Alina, right now we will do the test immediately, and it will help us to pick up the condition early if it is present. Sometimes what happens is that there may be very minute bleeding, and it is recognizable after a certain time delay. And so it is advisable to be completely sure. Like I said, the condition is life threatening. So we have to be completely sure that you don't have it because you have given the symptoms of this condition. So we have to be completely sure that you don't have it. So we have to repeat it.
Yeah.
And then if it is negative, then we'll observe you for some time for any side effects of the test. And then you can call someone from home who can
So
come
you
to
mean
pick you up.
you mean, doctor, if this test is negative, so this means that I have no bleeding.
Yes, if the second time the test is negative, then it will be confirmed that you don't have the bleeding.
And if it's positive, what you will do, doctor?
Well, if it is positive, we'll involve our brain specialist and they can give you certain medications through your blood channels and which will help to lower down the
Yeah.
pressure around your brain, and we'll also monitor you for any changes,
Yeah.
any and your blood pressure as well, which will be have to kept within a limit, and for any side effects of the procedure or of the any complication of this problem, and we'll
Yes.
regularly monitor you, and then in the longer run we can do tests to find out the exact cause and we can treat that as well.
Okay. Thank you, doctor. Thank you very much. Time. If you have time.
So, Mrs. Alina, any more concerns that I can answer?
No, doctor.
So
No.
I
Thank
will
you.
give you some
Thank you.
leaflets, brochures, and websites about this condition. You can read up more about the subarachnoid hemorrhage as well as the lumbar puncture in detail. We will
Yeah.
take a consent from you before the procedure, which will be signed by you, and you
Yes.
can withdraw the consent at any time before the procedure. Someone will come and explain to you again about it. Who will be doing the procedure will be explaining to you more in detail about it.
Thank you, Dr. Komel. Thank you very much.
Thank you.
You see, you survive yourself in the last seconds.
I
Consent. Why?
forgot about the consent.
Why you forget consent? This is the most important issue. This scenario, the main purpose from this scenario to talk about the consent. Really. So you forget it. The second point, doctor. So this is the most important legal issue here in this scenario, that consent. So the legal issue in this scenario is consent. Okay, Dr. Komel. The other questions, when you will do LP,
One
FCT.
LP will be done immediately, and if it
Why?
is negative,
Why?
we'll do
Why
again.
immediately? Why?
Uh,
Why you the patient suffering 2 times from lumbar puncture? Lumbar puncture is not easy or not comfortable for the patient.
so we'll not do one. I thought one is done right now, and then to
No,
confirm it
no,
again.
no. Only do after 12 hours after onset of symptoms. After onset, not after presentation to hospital. After onset of symptoms. Only one time. After 12 hours after onset of symptoms, not 2 times. So really, now when you tell me twice, so I will refuse. Really, I will refuse. Twice you will inject insert the needle in my back, and so it's difficult for me. So one time, but after 12 hours. This is very important to inform the patient that because she will ask you an exam when you will do this test. Tell her that usually this test need 12 hours after the onset of symptoms to do it, because most likely will be negative in the first 12 hours.
And after that, do we
So
repeat, or is this the only
no,
time?
no, 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 no need, no need. One time
Okay.
only. After 12 hours, one time you can do it. So the other questions, this also will be asked by the patient, and I asked you, if a brain CT and LP are negative, so does it mean that no subarachnoid hemorrhage?
I think so. Then there is no subretinal.
Yeah, usually, really, patient with negative CT and lumbar puncture findings have a favorable prognosis. However, lumbar puncture findings can be negative in approximately 10 to 15% of patients with subarachnoid hemorrhage. So this means you can answer the patient that the possibility to have a bleeding if these tests are negative very low. Okay, but this is
Okay.
not 100%, but the possibility very low, and then we need to observe you more for other clinical manifestations. So the last question: what are the complications of subarachnoid hemorrhage that we should discuss with the patient? We should tell the patient to accept our procedure, to accept our treatment. What we should tell him about complication rather than rebleeding that you mentioned for me.
I mentioned that it can cause fits, it can cause decreased
Yeah.
conscious level, focal neurological deficit, and it can be
Why focal neurological deficit can cause?
uh, if it compresses a part of the brain, then it can.
Vasospasm.
And
Vasospasm. So this vasospasm can cause sometimes ischemic manifestations. Okay, and the last one, hydrocephalus. Hydrocephalus that is also can be acute or chronic and can cause decreased level of consciousness. You are right. So first of all, when we start our meeting, our session 4, first of all we should introduce ourselves as you do. So for other candidate, first of all, introduce yourself to the patient, and then confirm the patient identity by his name and by his age that given in the scenario. Okay, then take permission from patient that you will talk about his condition, and this permission mean uh, you can tell the patient what's your agenda also in this scenario. So you can tell the patient, we are here to talk about your health condition today, so it's okay for you. So this means you are taking permission and in the same time explain the agenda of the patient. After that, next step, you should ask patient in this scenario if she would anyone to attend with her, because as you know that this is a serious disease and difficult disease, so maybe the patient need support with him. After that, you should ask the patient what he know about his condition so far. This is important questions to know what the patient informed and what he know now, or what he expectation about disease. And you can also ask the patient about his expectation. Maybe the patient tell you that I know that I have bleeding, or I know, so this is will make the scenario more easy for you. So expectation, this is can make the scenario more easy for you. Like I will give other example. Sometimes the patient tell you, uh, if you are talking about cancer, sometimes the patient tell you, yes, I suspect that maybe I have cancer, so this may they will make the scenario more easy for you. So this is for introduction for any station 4, and there is marks for each step of this. So first of all, introduce yourself, uh, confirm the patient identity, and then ask the patient to take permission and about the agenda, talk about the agenda, And then you should ask patient if she would anyone to attend with her. Then ask her about what she know about her condition so far, and the last thing, what's her expectation. Then you should talk about the subarachnoid hemorrhage and lumbar puncture. Subarachnoid hemorrhage, it's very easy to talk about subarachnoid hemorrhage. First of all, tell the patient what's the meaning of subarachnoid hemorrhage. What's the meaning of subarachnoid hemorrhage? And then you should tell her what the symptoms. So for any disease, not only for subarachnoid hemorrhage, for any disease, how can explain the disease for any patient? First of all, tell the patient what the meaning of the disease, definition of the disease. Then what the symptoms of the disease. Third, what complication? Complication is very important to mention for the patient. Why? To convince the patient to accept further investigation and your management plan. Then tell the patient about prognosis if she don't ask you, if she doesn't ask you about prognosis or what's called outlook. So you should tell the patient about outlook. Very important. And then you should mention for the patient what treatment available for this disease. After that, if there's any investigation should be done, like in our scenario, you should explain about this investigation. So for any disease, start to tell the patient the definition of the disease, clinical manifestations, complication, prognosis, and treatment. This is very important steps, 5 steps. And investigation, if it's requested in the scenario, you should explain the patient about investigation. Subarachnoid hemorrhage. What's subarachnoid hemorrhage? Subarachnoid hemorrhage, for patient language, it's a form of a stroke. Is it stroke? So it's a form of a stroke that in which bleeding occur into fluid-filled space surrounding the brain. This is called subarachnoid space. It's easy. Form of a stroke in which bleeding occurs into the fluid-filled space surrounding the brain. And this is what it's caused, usually caused by rupture of a small peri-like swelling on one of the blood channels in the brain. And there are also other causes we should look for it. So it's usually caused by rupture of small peri-like swelling on one of the vessels in the brain. And you can tell her that it's called aneurysm. And usually it causes severe headache, feeling sick, and throw up, and sometimes can cause loss of consciousness and fit. Subarachnoid hemorrhage, now you should mention this is for patient. Subarachnoid hemorrhage considered medical emergency. It's considered medical emergency to convince her to stay in hospital and to convince her to accept next procedure. So subarachnoid hemorrhage is considered medical emergency and can cause catastrophic complication like permanent disability and death. So we need to diagnose it early to avoid these complications. So I will repeat, subarachnoid considered medical emergency, and this can cause catastrophic complication like permanent disability and death, or you can mention life-threatening. Okay, and you should mention now complication. Many patients who survive from the first bleeding can develop other bleeding within 2 weeks, and this rebleeding is usually more severe and can cause life-threatening complications. So you should mention for the patient complication of rebleeding. Why? Because this is the most serious complication of subarachnoid hemorrhage, and most patients who suffer from rebleeding, this can be die. And you can mention for her also this can sometimes cause other type of stroke, and this can cause disability for you. Now, a brain scan usually show the bleeding in most cases, but sometimes can be normal like in your case. But this does not mean the patient has no bleeding, especially that your complaint and examination make the possibility of subarachnoid is very high. So we need to do further tests to confirm the diagnosis and to avoid complication in future. Okay, so now about procedure. First of all, for any procedure, not only for lumbar puncture, for any procedure, how can talk about any procedure? First of all, tell the patient what's this procedure. Before to explain about the procedure in details, tell what this procedure that in subarach. minute. Yes. So for procedure, you should explain the patient what this procedure and who will do this procedure, the steps before to do this procedure, the technique of a procedure, the common and serious complication from this procedure, and you should talk about precautions that should be taken if the patient has any complication after this procedure. So first of all, you should mention for patient that lumbar puncture, it means spinal tap, is a procedure where a sample of brain fluids taken for testing. And you can explain about this is fluid. This is a fluid that surrounds the brain and spinal cord. And here I advise you because it's very easy for you to ready to draw for the patient. It's very easy to draw here. You can draw two vertebra and explain that this procedure will insert the needles between these two bones that called vertebra, and this needle will reach to the space called subarachnoid space and will collect the fluids from this area. So here it's very easy to draw. Ready? I mean, really, if you see the leaflets that leaflets of Royal College or leaflets for the patients in the websites, you will find that sometimes they draw something for the patient, and this is really only for to explain in more easy way for the patient how can do this procedure. And in explaining of lumbar puncture, really it's very easy to draw for the patient. Only draw two bones, vertebra, and tell the patient that this is bones called vertebra, and will insert the needles between these two bones uh, to collect the fluids. Who will do it? Who will do it? Expert doctor. You should tell the patient that the one will do this procedure is expert doctor, that he did this procedure many times before, to reassure her that no training doctor will do it. Then you can explain about this procedure that will clean an area in your lower back and will with antiseptic and will then inject some medication into small area of skin. This stings a little at first, but then makes skin numb. And the doctor will push the needle through the skin and tissue between two bones called vertebra into the space around the spinal cord, which filled with this is fluids. And then you can tell her that the doctor will collect some fluids to send to lab for testing, and then will pull the needle and cover this area with plaster. Okay, complication. What most common complication of lumbar puncture? Headache. The most common complication is headache, and this usually tell her the patient that some people can develop headache after this test, and this usually go after few hours. And how can decrease the possibility of headache? It's best to lie down for a few hours after the test, and this makes the headache less likely to develop. This is very important point. So lying flat after the procedure, not to prevent the infection or prevent the bleeding, no, to prevent the headache. This is very important point. Okay. The other complication, infection and bleeding of the site of the needle entry. For paralysis, what the cause of the paralysis in patient after lumbar puncture? Dr. Komil, what the cause of paralysis?
If there's any, if we damage the spine,
How can damage the spine?
that
Technique. Wrong technique.
What?
Wrong technique. Like this.
Oh,
Damage to the nerves around the or
you feel that yeah,
equine-
this is a good answer. Subdural hematoma. You feel that the doctor, or neurologist, or any doctor will do lumbar puncture at the level of spine. Nobody will do at the level of spine. So most likely the paralysis will cause by subdural hemorrhage that occurred during the procedure. This is the cause, not the injury of the spinal cord. And you can mention for the patient, sometimes the patient during the procedure will feel pain in his leg. This is because usually irritation of the nerve roots. This is can cause by irritation of the nerve roots, so the patient may feel burning sensation or pain in the limbs, but not weakness, not weakness. So the weakness usually caused by subdural hemorrhage that can occur during the procedure. So here you should tell the patient very important point before to talk about the complication. Tell her the benefit that will gain from this test to confirm the diagnosis early and avoid serious complication overweight the complication that usually rare with good hands. Very important in each procedure to mention this phrase. The benefit will gain from this test to confirm the diagnosis early and avoid the serious complication, overweight the complication that usually rare. Don't let the patient ask you. Tell her before to ask you. So tell the patient about this, that the benefit more, before to tell her what the complication that can occur with the patient. As we mentioned, for lumbar puncture, headache, don't forget headache, and infection, and tell her that this is very rare because we are taking precautions before to do this test, and tell her that also bleeding, also it's very rare, and sometimes due to this bleeding, sometimes the patient can feel weakness, and if we pick it early, this can be managed easily and completely. As we know that subdural hemorrhage is very easy to be managed. And then precautions before to go, and you tell the patient either if she will stay in hospital or discharge home, because if she stay in hospital also she should know when she call the nurse. It's very important. Not only when the patient go home, also if the patient will stay in hospital, you should tell her that about the precautions that should seek medical advice or should call the nurse. If the patient have severe headache, if she has high body temperature, if she has weakness in lower limbs. This is the precautions that should call the nurse directly or seek medical advice if the patient discharged. Consent. Don't forget consent. Any procedure need to talk about the consent. And when we talk about the consent, tell the patient that this consent, especially for those who will take examination in 2021, because no questions after the scenario, after the station 4, no more questions from the examiner. So you should talk about the consent. Consent, you tell the patient that it's written what we are discussed now about the procedure, how can be done, who will do it, about the complication. Okay? So the consent, you should explain the patient what the meaning of consent. Consent, this is, it's written what the information we discussed together now, all complication, who will do this procedure. Okay? And take your time, read it carefully and take your time. And if you feel any time, if you don't, if you would not to do this test before, any time before this procedure, you can withdraw. So this is very important point about the consent to discuss with the patient. As I mentioned, the procedure will be done after 12 hours after onset of the symptoms. This is very important to mention for the patient. If the patient tell you, if this test positive, what you will do, doctor, after that, you can tell her will involve the other doctors called neurosurgeon, and also will do other tests that can be do scan of the blood channels called angiography. If the patient asks you about this everything about subarachnoid and lumbar puncture. If anyone has a question, please, I can answer.
Dr. Hassan, I need to ask one question regarding, like, not regarding the lumbar puncture, but sometimes the procedure comes like a biopsy, like we have to discuss the patient regarding the lung biopsy or
Yes.
any other
Yes.
biopsy. So in that case, there are the multiple ways of doing the biopsy. Sometimes we are doing it through a percutaneous way, or sometimes through the like open biopsy.
Yeah.
So is it always mentioned in the scenario that what exactly we have to mention?
Not always mention in the scenario. If they mention in the scenario the way of this procedure, you should only talk about this way. But if not mentioned, you should explain the patient about all ways that can be used in this when take biopsy. So if they mention, you should follow the instructions. But if not mentioned, you should explain that this can be taken like this and like this.
Okay, that means we should, like, if it is not mentioned, we have to tell the patient that it can be done through an open surgical incision we have to give, or it can be also done by.
Yeah, if not mentioned, but usually really they mention it.
Okay.
Because sometimes no time to explain about all way of procedure 14 minutes you should explain the patient about the disease and talk with him and answer his concern. So most scenario will give you the way how can do this procedure.
Thank you, sir.
Thank you.
Where is the
Yes, doctor.
location for the lumbar puncture in the spinal cord? Exact
I
location.
can't. Sorry, I can't hear you.
Yeah. My question is that where is the exact location for the lumbar puncture? It is the
Yeah.
most more
Yeah.
vertebral space. Exact location for the lumbar puncture.
Yes, doctor. Yes, there's exact location you can do between L3 and L4.
L4.
Yeah,
Oh.
and L4, L5 also. Yeah, I mean this is no, you don't suspect that any doctor he will do lumbar puncture will go up to the level of the spinal cord.
Mm-hmm. Okay. So how will you explain to the patient that we will go for the lower?
Tell her that we'll insert these needles in the side. There is no spinal cord that this can cause injury and also paralysis for you.
Okay. Okay. And Dr. Hassan, is there any role of the MRI or MRI in the subarachnoid hemorrhage for the diagnostic purpose?
Yeah, actually, the sensitivity of MRI to detect subarachnoid hemorrhage it's low. Like CT. I will explain you. As we know that the sensitivity of CT scan to detect the hemorrhage it's 95%. Okay? The sensitivity of CT scan 95%. The sensitivity of MRI is less than sensitivity of brain MRI. So the investigation of a choice to do CT first. And if CT is normal, the second step, lumbar puncture, not MRI. And to diagnose the cause of subarachnoid hemorrhage, you should do MRA. MRA to see if there's any aneurysm. Before they talk about the diffusion time and flare time, that also there's high sensitivity, but really nowadays they change it that they told that sensitivity of MRI, including flare time, also is less than CT.
So after the confirmation, then we will go for the MRI to see is there any aneurysm.
Yeah, you are right. After that you can go to the MRA or angiography. Angiography.
Okay, in this sir, angiography of which artery? Basilar?
This no, angiography DSA. Digital DSA angiography.
Digital
Please repeat, sir.
Dr. Hassan, can you?
Sir, I can't hear you.
Yeah, I mean, if the patient confirmed that this patient has subarachnoid hemorrhage, you can go to the next step by non-invasive procedure like MRA or invasive procedure DSA angiography.
Dr. Hassan, can you please tell again, like how to tell the patient when she asked me, can it cause paralysis? So one is that if we won't insert it at a point where the spinal cord is present.
Yeah, weakness, yes, can cause weakness, but this is due to bleeding. And tell her that the possibility of weakness is very low with the good hands and this can cause by bleeding while insert. This is needle in the between the vertebra, but not but because the injury of the spinal cord.
Sir, excuse me. Sir, as we discussed that after lumbar puncture, if it's positive, we should go for further CT angio. What if the patient refuses the lumbar puncture initially and tells that you directly go for CT angio?
You cannot go. You should follow the steps. How can do for CT angio or MRI angio without to confirm that this patient has subarachnoid hemorrhage? Maybe this patient has no subarachnoid hemorrhage now.
Okay.
First, you should this clinical manifestations consistent with subarachnoid hemorrhage. First, we should confirm that this patient has subarachnoid hemorrhage, and after that, we can proceed for other investigation.
Okay, thank you, sir.
Especially that this angiography is also invasive procedure, and this is have many complications.
Okay, sir. Thank you.
Thank you.
Well, what about air travel after lumbar puncture? If the patient asks, I want to fly,
No problem.
can fly
Yeah,
immediately?
can fly. Yeah, for you mean for subarachnoid hemorrhage or for lumbar puncture?
For lumbar puncture.
No problem. She can fly.
If it is negative, then we can discharge.
Yeah, if as I told you, you can tell her that the possibility to be bleeding in your brain if it's negative is very low. So here you can give her precautions that if she develop headache, because really if lumbar puncture is negative, the possibility is very very low.
And so, for how long we'll observe her after the lumbar puncture before discharging her?
Yeah, you can't charge her. If lumbar puncture is negative, you can't charge her and tell her if she develop other headache or feeling sick or like this to come back to hospital.
We can discharge her immediately.
Yeah,
or
yeah,
do we
yes.
observe?
Usually, as we know that after lumbar puncture, you should observe the patient usually 4 hours to
4 hours.
to see complication of lumbar puncture. After that, the patient can go home.
And so, what about if the patient has subarachnoid hemorrhage? Then air travel for how long is restricted?
Air travel, if the patient has subarachnoid hemorrhage, like any patient has any stroke, so you should restrict it for 1 month.
1 month. And sir, did I say it right about driving that she should stop
Yeah,
driving?
I remember this one. I remember this point. No need here to counsel the patient about driving. This patient has no seizure, has no focal deficit, so no need to counsel her about driving at all, doctor.
Okay.
Yeah.
And
Because
sir, okay, sir. Continue, sir.
Because I mean the patient has no fit hair, no focal deficit, so no need to counsel her about the. And now the patient in hospital, so you will manage her, so you will discharge her with full management.
And
One
sir,
question.
if she develops subarachnoid hemorrhage, if it's positive, then do we counsel against driving once she's discharged, or not?
Why? Why? No, no need. Why? Because here, I mean, for counseling of driving, only if the patient has vision problem or have loss of consciousness. This is the main two causes of counseling of the, or if the patient has weakness in the lower limbs.
So, sir,
This is the indication.
if this same patient came in station 2 with loss of consciousness, we will counsel for driving.
Yeah, if
Yeah, but
loss
in
of
this,
consciousness, you
yeah.
should.
But
Yeah.
now there is no need.
Yeah, I mean, if the patient present with fit, you should counsel for driving.
Sir, if the patients develop the paralysis, the pathology of this is the damage for the nerve fiber, or pathology is the subdural hematoma or the paralysis?
You mean after lumbar puncture?
Yeah, after lumbar puncture.
No,
Yes, sir. My also query, because I read cauda equina can also be damaged by lumbar puncture.
Yes, cauda equina usually when insert the needles, many times it occur with us. When they insert the needle, the patient he tell you, doctor, oh, I feel burning, very severe burning sensation, very burning pain in my limbs, but will not affect, will not cause weakness, only will cause burning sensation.
So it affects also the nerve fiber as well in the spinal cord?
Yeah, yeah.
So if the nerve fiber damage, patient develop the paralysis. If the
you see, doctor, I will tell you. As we know that spinal cord, the nerves, all nerves will be together, will pass together. While in cauda equina, the nerves will be separate, much separate. So it's difficult to cause severe injury when you insert the needles into cauda equina. But if you insert the needles inside the spine, so will cause injury for a large number of fibers. So for this reason, can the patient develop weakness? And be sure that this weakness will not even. I will tell you something important thing. The needle is very thin, not thick, as I know. Okay, even if you insert this needle inside the spinal cord, okay, the injury will not be severe. Like if the patient develop, I will tell you, if the patient develop myelopathy, partial myelopathy, not severe, not transverse myelopathy. In transverse myelopathy, will affect all the fibers, so the patient will develop paraplegia. But if the patient develop only partial myelopathy, so the weakness will be not severe. Only the patient will develop paraparesis, not paraplegia. You understand my point? So when you insert the needle in cauda equina, also if cauda equina, so the nerves will be separate, so will not cause severe injury for the patient. So maybe only the patient will feel mild numbness or mild weakness because the nerve is not collected together in this area.
Right.
But if the patient develops subdural hemorrhage, as we know, subdural hemorrhage can extend and cause compression of all the nerves and sometimes can extend at the level of the spinal cord up. Other question, please.
Yes,
If
sir.
no, if no question, we can go to second case, station 5.
So sorry, I have to go to break my fast. Thank you, sir.
Thank you, Dr. Shaheen.
Thank you, sir.
Thank you. Second case, Dr. Abdullah, you are here?
Yes, I'm here, Dr. Hassan.
Station 5. I will give you 2 minutes. Abdullah, start, please.
Yes, hello.
Hello.
Yes, I'm Dr. Abdullah, your doctor in the dermatology clinic today. Can I confirm that you are Mr. Simon, 45 years old?
I'm Simon, doctor.
Okay, nice to meet you. I got a letter from your doctor that you are suffering with this rash.
Yes.
Can you show me the rash, please, Mr. Simon?
Yes, doctor, it is the rash.
Okay, and this, since how long this rash with you?
Actually, doctor, I have skin rash since I was child. But over the last few years, I have developed other type of this rash that really looks different and cause social problem for me also.
Okay, and this rash involve all your body or all your body?
Yes, doctor, in my neck, in my back, and hands also.
Okay, is it painful?
No, not painful, doctor.
Okay, is it itchy?
No.
Okay, is it oozing?
No, doctor.
Okay. So, Mr. Simon, can you tell me if there is any recorded medical condition before rather
Yes,
than this
doctor.
rash?
Yes, doctor, I have hypertension.
Okay, and this hypertension since how long, Mr. Simon?
Since 5 years.
Since 5 years. Okay, and are you taking medication for that?
Yes, doctor, I'm taking medication.
Is it controlled?
Really, doctor, not controlled well.
Okay, can you tell me please any family history with this similar condition?
Actually, doctor, my parents passed away when I was child because car accident.
Sorry. Thank you.
I'm sorry for that. Any increase in your blood sugar level?
Wait a minute. No, doctor.
Okay. Any hearing problem, Mr. Simon?
No, doctor.
Okay. So, can I examine you, Mr. Simon?
Yeah, please, doctor.
Yeah,
What you will exam? What you will exam, doctor?
First, I want to examine the rash.
Yes.
Okay.
What,
And
how can I examine the rash?
I will check the size of the rash, distribution.
Yes, distribution, very much.
And the shape also.
Yes.
And I will check is it painful or not.
Yes.
And I will see if punchable or not also.
Okay. You will look to the other rash?
Yeah, I want to check if there is any cafe or spot also.
And also?
And I want to check this axilla also.
Axilla for what?
Axillary freckles, if available.
Freckling, yes. Very nice.
Yeah. Yeah, and I will check his face also.
Face for what? You see, this is what this Dr. Abdullah?
I think.
With this cafe au lait spot.
This cafe au lait spot, yes.
Yeah. And this here, there's axilla.
It's axillary freckle.
Yeah. And this also cafe au lait spot.
Cafe au lait spot, yes.
And here very clear, more clear. You see. It's clear now. This flickering. Not very clear, but okay. What you will exam also?
Okay. I want to ask. I want to check eyes also.
Eyes for what?
I think if there is any, I want to do fundoscopy.
Fundoscopy for?
I think some gross. I'm expecting to see if there is any gross.
What else you will do?
Visual acuity and visual field also I will check.
Visual acuity, visual field. Okay, what else?
Yeah, I want and I want to ask also if there is any change over his water work also.
No, doctor, no problem. My water work.
So, Mr. What was the answer? I did not hear it, Dr. Hassan.
No problem in water work, doctor.
Okay, I want to. Then I will check vitals also.
Check vitals, blood pressure 155/90. Pulse 90 per minute, regular.
So I want to ask regarding work performance or study performance, if he's doing anything also.
Yes, doctor, I'm good.
So if possible to
I'm working, doctor, and I have family. No problem.
Okay, so and you told me no family history of similar condition. Am I right?
Really, doctor, I don't know because my parents passed away when I was child because car accident.
Okay. And what about driving?
Driving, I'm drive my car. I have car, doctor.
Okay. Any vision problem?
Really, doctor, yes, I have vision problem. I also seek advice from eye doctor. He told me that I have now mild cataract.
Cataract. Okay, so
Yeah,
uh, we
in my right eye, and told me now, can we wait for surgery later on?
okay, so we will help you regarding this, and we will seek advice of eye doctor also. He is one of our team. What about alcohol intake and smoking, Mr. Simon?
Well, doctor, I'm not drinking and also not smoking.
Okay, so can I know your concern?
What the cause of these lesions, doctor, in my skin?
Yeah, this Mr. Simon, from information I got from you and after examining you, I think you have a condition called neurofibromatosis,
Yes.
and this is a genetic disease. That means it's run over family, and we need to make a multidisciplinary team,
So,
and
doctor,
we need to do.
I noticed that my son also has some skin rash. So, does it mean that my son also will develop this disease?
Yeah, there is a possibility of running of this disease over your son, and we need to we need to refer you also to genetic clinic, and they will advise you furtherly, and maybe they need to make a screening to your family also.
Okay, thank you, Abdullah.
Any other concern, Mr.
Thank you,
Simon?
Abdullah. Thank you, Abdullah.
Thanks a lot.
First of all, Dr. Abdullah, when you pronounce the patient name wrong and the patient inside tell you his name correctly, so you should know his name exactly. I told you I am Simon, not Simon. Okay? Better to pronounce it better because I correct you when you tell me at the beginning Simon. I told you I am Simon, so you should know this very important point because maybe the patient will be irritant if you mention his name wrong. The second point, as I told you before, that this case of spot diagnosis. So we should look for complication. Okay? What complication of patient with neurofibromatosis?
I think renal artery stenosis, I'm remembering this.
Yeah. So why don't examine the abdomen? Why don't examine the abdomen?
Yeah, I need to examine the abdomen, but until no change over water, or but I need to examine it.
Will not cause water work changes. Renal artery stenosis will not cause renal artery changes. Only will cause hypertension. Is that
Yes,
right?
you are right. I need to examine his tummy. Yes.
What the cause of hypertension in patient with neurofibromatosis one?
One of the causes is renal artery stenosis itself.
The other cause is important cause.
I think cardiac problem, I think.
Pheochromocytoma.
Yeah, malignancy.
And this patient has pheochromocytoma. If you ask me about symptoms of pheochromocytoma, I will tell you. When you ask me about my blood pressure is controlled or no, I told you no. So why no? You should know why no. Okay, so you should rule out secondary causes, and secondary causes of hypertension in patient with neurofibromatosis is renal artery stenosis, and the second common cause pheochromocytoma, and this case of pheochromocytoma. What other complication of the patient with neurofibromatosis?
I think cardiac problem also.
What this?
Cardiac problem.
Cardiac problem. Yes, you are right. Can cause cardiomyopathy.
Yes. Other
and
also.
musculoskeletal features. Kyphoscoliosis. Charcot joints, bowing of the long bones. This is three can be caused, and most patients with neurofibromatosis will have back pain due to kyphoscoliosis. So you should ask about back pain. So when you examine the eyes, okay, first, What's your diagnosis?
It's neurofibromatosis.
Not enough.
Type 1, I think.
Type 1. Type 1.
Yeah.
Because as we know,
type 1.
neurofibromatosis type 1 is a peripheral disease, while neurofibromatosis type 2 is central disease.
Yeah.
Okay. So, what do you know about diagnostic criteria for neurofibromatosis type 1?
In children, I think more than 5 cafe or letter spot is suggested.
Six or more. 6 or more.
Yeah.
Diameter more than 5 millimeter pre-pubertal and more than 15 millimeter post-pubertal. Also, what else?
I'm not sure regarding others, Hassan.
2 or more neurofibromata of any type or plexiform neurofibromata. 2 or more leash nodules. How can examine leash nodules in the eyes? You need slit lump. Slit lump. So you don't mention to the examiner that I see the leash nodules. So tell the examiner I need to examine this patient with a slit lamp to look for leash nodules. Axillary or inigual freckling, optic glioma. Okay? And also if the patient has any bone lesions and first degree relative with neurofibromatosis type 1. When you ask about family history, you ask about his family history, his parents. Why don't ask about his siblings? Because as we know that disease can develop since childhood. So here when he tell you that my parents passed away before due to car accident, you should ask him, are you married? Yes, I'm married. Doctor, do you have kids? Yes, I have kids. Any one of them have similar condition? Also, you should ask about kids because to know that this is family disease. This is one of the criteria to diagnose neurofibromatosis that first degree relative with neurofibromatosis. So you ask about his parents. You ask because it's family history. You should concentrate on family history here. Not enough to ask about his parents, his brothers, his siblings. So you should ask this because to confirm that this is because it's family disease. What is the mode of inheritance?
For neurofibromatosis.
Autosomal
Autosomal dominant, I think. Yes.
What medication? What treatment?
Treatment for this angiofibroma, I think laser therapy for this and surgical removal of this neurofibroma.
Yes.
I think cosmetic therapy.
Okay, surgical therapy can be used to remove the tumors that can cause pain or loss of function. We cannot do surgery to remove all these tumors. So only can be used for that cause pain because some tumors, some neurofibromata can cause pain. So only the indication of surgery to remove tumors that can cause pain or loss of functions, or if there is any malignancy, malignant features. Okay, this is the other indication. Also, chemotherapy can be used if there's any cancer tumors. So chemotherapy can use if there's any cancer tumor. Try to avoid radiation therapy. Radiation therapy should be avoided. Okay. Also, this is very important point that if we suppose now the scenario in exam come with neurofibromatosis type 1, but the patient has no hypertension. He told you, I have no past medical illness. So very important here in management plan to educate the patient for monitoring of blood pressure because can be developed anytime. So very important point. So first of all, check regular checking of blood pressure. And also, you should tell the patient there is no curable treatment for neurofibromatosis, and routinely you should monitor it for complication. Complication, as we mentioned, hypertension due to renal artery stenosis or pheochromocytoma, complication of malignancy. This is very important that this can be develop malignancy. Also eye complication, very important eye complication, and also cardiomyopathy, and sometimes the patient can cause develop lung fibrosis or pneumothorax also, pneumothorax or pulmonary fibrosis. Okay. For blood pressure, how can I manage this patient for blood pressure?
To avoid nephrotoxic medication, and
Now this patient is taking lisinopril, so it's a good option for him, or you will change it.
the need to be changed to other antihypertensive rather than Zilobril.
What if the patient, I told you that he has pheochromocytoma?
So if the cause of hypertension is pheochromocytoma, so he need alpha blocker and then beta blockers and surgery.
Yeah, alpha and beta blocker. We start usually with alpha blockers and then we'll go to the beta blockers, okay? Or we can start together. And maybe indicate for surgery, surgical therapy, that we know that this is treatment of a choice for patient with pheochromocytoma. Okay. So this case,
doctor, I think these patients also may have renal artery stenosis.
yeah, we mentioned the main causes of hypertension in patients with neurofibromatosis, renal artery stenosis, and and pheochromocytoma. So it's critical to examine the abdomen to look for probability of renal artery stenosis. Very important.
Okay.
So examine. How can examine this patient? How can examine this patient? Very important point. First of all, you should ask the examiner about observation chart. Then inspection to see if the patient inspection for what? For to see caveolate spot should be more than 6, okay, and also to see neurofibromata and detect where's this, okay, and see of their axillary freckling. And then you should examine musculoskeletal to see if there's patient has kyphoscoliosis, charcot joints, and bowing of long bones. And then you should go to the eye. Very important to examine the visual acuity. Visual acuity, it's affected with patient with optic glioma with cataract, because patient of neurofibromatosis can has cataract, can has optic glioma, and also as we mentioned this lesh nodules, but lesh nodules need to be examined by slit lamp. Tell the examiner I will need slit lamp to examine for lesh nodules, and then examine the abdomen for renal artery stenosis. So examine the abdomen for renal artery stenosis, and you can tell the examiner I would to complete my examination by examining the chest and heart. Why chest? For pulmonary fibrosis, and why heart? For cardiomyopathy. This is how can examine the patient.
Again, Dr. Hassan, items of examination in neurofibromatosis.
Yeah, we start first of all with looking for the features of neurofibromatosis. What are features? Caveolate spot and neurofibromata. See where's this neurofibromata, okay, at the level of nerves or at the level of plexus, and then see if the patient has axillary freckling. Then go to examine musculoskeletal, kyphoscoliosis. This is only with inspection you can look for it. Charcot joints, look to the ankles, especially at the level of the ankles. Growing of long bones, the tibia bones especially. Then examine cranial nerves, especially for optic nerve. Visual acuity, visual field not important, visual acuity, okay, because most patients will be decreased visual acuity due to cataract or optic glioma. And then you can tell the examiner I will do fundoscopy to look for optic glioma and retina hamartoma, and also tell the examiner I will do slit lamp for lesh nodules. Don't tell him I will look for lesh nodules by fundoscopy. You need slit lamp for this. And then go to the abdomen, examine for renal artery stenosis, it, and then tell the examiner I will complete my examination by examining the lung and heart. If he asks you why, because this disease can be complicated with pulmonary fibrosis and also cardiac myopathy. So this case spot diagnosis. I mean, when you go inside the examination, first questions for patient has skin lesion, you will ask him, show me this lesion. So when the patient show you this lesion, so you know now that you have neurofibromatosis. So first of all, try to elicit, ask the patient. If the patient show you this is neurofibromata, ask the patient, do you have other rash? He will show you that he have coffee a late spot, and also ask him to show you the axillary. So you can see also this is freckling. Then confirm the diagnosis. How can confirm the diagnosis? As we mentioned that it's autosomal dominant. So ask the patient about his family history. If the patient tell you, my parents passed away when I was child, so here ask you, are you married? Do you have children? Any one of them have skin lesions? Because as we know that this disease appears since childhood, especially for caffeolate spot appear since childhood. But neurofibromata can appear in adult age. Then ask patient about hearing and visual symptoms. Why hearing symptoms? Hearing symptoms to rule out neurofibromatosis type 2. Type 1 will not cause hearing deficit, but hearing deficit can be occur in patients with neurofibromatosis type 2. And then ask about visual symptoms directly to rule out cataract and glioma, and this can occur in both, in type 1 and type 2. Then ask the patient about back pain and bone pain. Back pain to rule out any musculoskeletal deformities that in the back, and also bone pain due to Charcot joints will not cause pain, but sometimes this pain can be due to defect like growing of the long bone also. Then ask the patient about chest symptoms. Do you have shortness of breath? Do you have cough, dry cough? Do you have leg swelling to rule out also neurofibromatosis and lung fibrosis and cardiomyopathy? So if the scenario come and the patient has no hypertension in the scenario, you should advise him that you need regular follow-up for blood pressure. The most important point in the patient with neurofibromatosis to observe blood pressure. As I told you now, this case, but Dr. Abdullah forget to ask me about pheochromocytoma symptoms. Very important to ask about pheochromocytoma symptoms in the patient with neurofibromatosis, and this case, neurofibromatosis with pheochromocytoma. Very important thing, and this come before in exam.
Sorry, can you repeat history questions again? Because there's some connection.
First of all, elicit the features. First, when you go inside, ask the patient, show me these skin lesions. See these lesions, okay? And look for to caffeolate spot rash. And also see the axilla to look for axillary freckling. Then confirm the diagnosis by ask the patient if any member of his family have similar condition, have similar disease. If he told you my parents passed away or like this, ask about his brothers and his sister. If he told you I have no brother and sister, ask about his son. Okay, very important because it's autosomal dominant. Then ask about uh, associations, hypertension. Hypertension, and if the patient tell you, yes, I have hypertension, you should ask about the symptoms of pheochromocytoma. Or if he has no hypertension, also you should ask about symptoms of pheochromocytoma. Then ask about hearing and visual symptoms. Hearing defect can be seen usually in patients with a neurofibromatosis type 2, not type 1. Okay? And visual symptoms can be seen in both type 1 and type 2. Then ask about musculoskeletal deformities. If the patient has any deformities like Charcot joints, growing of long bones, or kyphoscoliosis, ask about any deformities and pain. Then ask about chest symptoms. Chest symptoms, shortness of breath, dry cough, leg swelling, to rule out lung fibrosis or pulmonary fibrosis, and cardiomyopathy.
Dr. Hassan, if you can also tell us the question that we should ask for the rash in station 2, specifically when we cannot examine the patient, and is blanchable a jargon or not?
Yes, blanchable jargon.
So how can we ask the patient?
You can tell if you press on these lesions, does this appear?
And can you please tell us few questions that we should specifically ask for the rash in station 2?
Yeah. For rash. For any rash in station, sorry, 1 minute. 1 minute. For any rash in station 2. I will tell you all question. Only 1 second, doctor.
Okay, sir.
So, any patient with rash in examination in station 2, not in station 5. So you cannot see the rash, okay? So ask the patient about the onset of rash. As we know, onset, course, duration, how this rash developed, and distribution. Ask the patient what the sites of the skin rash, and ask him if it's intermittent or persistent. It's come on and off or persistent. And ask about the color, okay? And ask about blanching by these questions. Does this appear when you press on this rash? And ask if it's flat or resin. You should know, you should ask because now you cannot see the rash, so you should ask whether this rash is flat or resin. And then ask about any exacerbating factors for this rash and any relieving factors, and associate if there any pain or itching. Pain and itching. Is there any oozing or discharge? And then, very important question, does the rash appear at the site of a trauma? This is for Kobner phenomenon. And also, you should ask patient if there any history of pee, stings, is there involvement of the face, lips, mouth, and tongue? As we know that some lesions can affect also mucosal membrane. And if there's any symptoms, very important to ask about symptoms of respiratory, like breathlessness, stridor, and wheezing. Why? Because as we know that this can be due to allergic rash or urticaria. And also here, last questions also for skin rash, you should ask about if there's any potential precipitants like perfume, like washing powders, like jewelers, like clothing. And you can ask also about do systemic review for all system, because as we know that some rash, if the patient tell you that I have nodules in my legs, so you should rule out the other causes like sarcoidosis. So very important to do systemic review. Any question, please?
Yes, doctor, please, Dr. Hassan. Regarding in this case, you told that there is a type of plexiform neurofibroma. Sorry, I read many times and I don't know exactly. This is mean the shape of the neurofibroma or it has a specific site. Yeah.
A plexiform, it will be in the site of a plexus. So where the site of plexus?
In the nerve plexus?
Yeah, nerve plexus. Yeah, it will be at the site of nerve plexus.
Okay. Thank you.
Yes.
You mean the doctor brachial plexus or femoral?
Brachial, yeah.
Dr. Hassan, can you repeat the criteria for neurofibromatosis if you don't mind, please?
Yeah, as we mentioned, neurofibromatosis criteria. Two or more neurofibromata, or one plexiform neurofibromata. Okay, two or more leash nodules, 6 or more caveolate spots, optic glioma, axillary or inguinal, freckling, and bone deformities, bone deformities, first degree relative with neurofibromatosis type 1. If 2 or more features are present, so this is diagnostic.
Dr. Hassan, you said plexiform neurofibroma will be at the site of plexus. So we look in the armpit, and for lumbosacral, where will we look?
Yeah, we know that the plexus sites we can see above the in the axillary area, and also in the inguinal area.
In the inguinal area.
Yes. What about the size? You told that 15 mm in the children. It is for the.
This is for caffeolate spots, more than 5 millimeter pre-pubertal and more than 15 millimeter post-pubertal.
Okay. Thank you.
So in case of neurofibromatosis, very important, this case will be related to hypertension. In most cases in exam related to hypertension. To know what the cause of hypertension in this patient, either renal artery stenosis or pheochromocytoma. They bring this case for this reason.
And Dr. Hassan, to assess hearing, will we have to do the Rene and Weber because there's no time in station 5?
Will do what?
Rene and Weber test.
For deafness, only ask him. Only ask him. As I told you that this is deafness usually associated with central cause. And usually in central cause, it's rare to see that peripheral manifestations of the disease. So only ask the patient about hearing. Another question, please.
You mean no need to inform the examiner that I want to make any.
No need, doctor. Because as I told you, this is neurofibromatosis type 1. It's clear. Because usually, as I told you, neurofibromatosis type 1 is peripheral disease, while neurofibromatosis type 2 is central disease, usually cause brain tumors. So no need here because only ask these questions about deafness. And if the patient has any deafness, so this means that type 2, and it's very rare in exam situation. And it's more neurofibromatosis type 1 more common in our life than type 2.
Solution or treatment of his condition.
Yes.
If he
tell
said
him that there is no curable treatment. Tell him that there is no curable treatment. Unfortunately, I am sorry to tell you that this disease, as I told you, this family disease or genetic disease, and there is no curable treatment for this. But we should do regular follow-up for you to see if there's any complication, and also we should observe this skin lesions frequently to see any progression of these lesions, because as I told you, this patient can develop also this malignancy. And we should do also regular follow-up for eyes to see if there's any eye lesions.
Any way to prevent inheritance of this condition to offspring?
As we know that there are some ways to avoid this. We talk about this many times. How can avoid the transmission of disease in disease of autosomal dominant? Any question, please?
Thank you very much.
Thank you, Doctor. See you next week, inshallah.
Thank you very much.